Good afternoon, everyone. So the presentation will be beginning shortly, but before that, we just wanted to go over some webinar logistics. If you look over to your right side, you will see that there is a closed caption feature that you can use. Also, there is a Q&A function. Questions will be captured during this webinar. Please make sure that you respond to all participants when you are submitting a question. Please note that the questions will not be answered during the webinar, but they will be captured. So please make sure to send your questions to all panelists.
Okay, good afternoon. Today we will be holding an OPWDD technical webinar. The topic of the webinar is the calculation of workforce stabilization, longevity and retention, supplemental payments. What we will be doing first is going over a few questions that are specific to this topic, and this will be the only topic we will discuss today is specific to the calculation of the longevity and retention supplemental payments. We will be discussing a couple of questions first, then we will be presenting some general slides with reference to the topic, and then after that we will actually go through a PDF sheet, a PDF calculation sheet for the calculation of the longevity and the retention payments. First of all, let's discuss some questions that we have received prior to this webinar that are specific to this topic. The first question, our agency auspice changed a portion of our residential programs to another provider. We continue to operate the balance of the residences. Should we develop a methodology to split the funding we've received with that other provider? And the response is yes. OPWDD and DOH did not consider the transition of portions of programs to other operators. Their calculations only considered wholesale changes of programs from one agency to another. As a result, in instances where less than the entirety of a given program transitioned to another agency, the receiving agency should develop an arrangement to appropriately compensate those other provider agencies who assumed oversight of such programs. The second question, how should we handle the facilitation of funds to our contracted agency to ensure they are distributed to the appropriate staff? The response, providers are encouraged to create a subcontract with their contracting agency. Third question, how can the agency ensure they are in compliance with FLSA and/or DOL compliance when they are distributing these funds? The response, agencies should refer to the questions and answers section of the website. And then for the final question, where should agencies be submitting questions related to the calculation of workforce stabilization payments? OPWDD will be establishing a new mailbox for payment calculation questions. We'll be sending a link to that mailbox to providers in a few days, and we also expect to post it on the web. All right, let us get started with the presentation. One second, please. The first slide is longevity and retention supplemental payment disbursements to providers. Longevity and retention supplemental payments have been made to the majority of eligible OPWDD providers. Payments are being recalculated for a few providers, primarily those that have undergone mergers or office changes, and for those, the monies will be paid shortly. The longevity and retention payments were derived from Personal Service Code 200, and that is specifically direct care on the CFR, and mandated fringe benefit information in agency CFRs for the period of July 1st, 2018 through June 30th, 2019, or January 1st, 2019 through December 31st, 2019. The backup PDF schedules to the longevity and retention supplemental payments have been posted to OPA. So all providers should be accessing those schedules. Hopefully you have done so already. The COVID service and vaccination incentive supplemental payments have not been made to any providers. The funding calculations will be based on previously submitted provider surveys. And as I stated previously, this particular webinar, this particular technical webinar will be specific to the longevity and retention supplemental payments. The COVID service and the vaccination incentive payments have yet to be distributed. Disbursement of longevity and retention funding to direct care staff and family care providers. First, the funding must be distributed in accordance with the stipulations and guidance identified in the attestation that was signed by your agency. A boilerplate copy of the attestation is available on the OPWD website, and we have given you a link in the slides to that address. The supporting and strengthening the direct care support workforce page on the OPWDD website contains additional information regarding distribution, including frequently asked questions and answers. Again, we have provided you with a direct link to that website and to those questions and answers. And I want to stress here this particular component. Utilizing the guidance available to the provider, it is the sole responsibility of the provider to oversee the appropriate distribution of the workforce stabilization initiative funding to agency staff. OPWDD will not address individual provider implementation issues. We feel that we have identified through your attestations, through the guidance on the website, all the information that is necessary for you as an agency to oversee this distribution and to oversee it appropriately in accordance to the attestation that you have signed. As provider decisions are made regarding the distribution of funding, the underlying principle should be that the interests and welfare of direct care staff and family care providers should be paramount in your decision-making process. Now we want to discuss communication to direct support staff and family care providers. For For retention payments made to direct support professionals employed directly by an OPWDD provider, utilizing the methodology described in paragraph B of the attestation, there are specific staff notification requirements identified in the format of a distribution plan. If you remember the attestation, it identifies two ways that the retention payments can be distributed. It can be the formula as dictated by OPWDD, and that is A, or there is the methodology that gives more discretion to the provider, that is B. If the provider chooses B, then that provider must adhere to the notification requirements that are stipulated in the distribution plan. It is OPWDD's expectation, however, that each provider will develop a plan for the distribution of funding associated with the 4 initiatives. Providers should make the plans available to staff and should be willing and able to identify to individual employees why that employee is or is not eligible for the payments and how the payment to the individual was calculated. The eligibility rules vary by initiative, so the eligibility identification should independently address all 4 initiatives, including the longevity and retention payments we are currently discussing, as well as the COVID service and vaccination incentive payments when they are made to agencies. OPWDD will not address individual employee inquiries regarding the workforce stabilization initiatives. Employees will be encouraged to speak with their employers. And now we'll move on to discuss an actual calculation.
Thank you, Joanne. Just click my video here. Hopefully everyone can hear me. So good afternoon, everybody. Thank you for joining us here. I appreciate Joanne giving us the, running over the, the overviews, around the initiative itself. Again, the premise here is that we're providing a framework. As Joanne, articulated, we've identified through both the attestation and our frequently asked questions and answers section on the strengthening our direct support workforce page. Other policy clarifications that have come through, including, questions surrounding retirement contributions and, the need to convert non-discretionary payments into, overtime rates through FLSA. All that information is being outlined, in one of those 2 documents. And we're going to continue to use the FAQ section to evolve, some common, questions that we see come through. Again, provider-specific questions about implementation, employee-specific questions about their eligibility. We're trying to stay as far removed from this as possible and give providers the discretion to administer. But as Joanne said, really, at the end of the day, the intent is to do the right thing for the direct support workforce. We all recognize there's, continues to be a workforce crisis, and we want each provider to be able to, manage the funding to pay their direct care staff. I think that's really the underlying tenet here. With that said, kind of just wanted to address the next several slides, and Joanne and our friends at DOH and at Deloitte, Aaron, can help, in the event that I have any other questions or they want to elaborate here, but wanted to kind of walk you through a couple examples, well, one example here, but looking at the longevity and the retention payment calculations and what components went into how we determined those rates of payment that, have been made available through eMedNI through both the state plan and waiver authorities, funded through Medicaid. So first and foremost, just trying to, you guys should all be pretty, set on the form here, the format of what we're going to go through. It's, a typical rate sheet PDF that you all have grown accustomed to seeing posted to OPA. Here we've got an example, Corp ID, but no one has a 5-digit 0 Corp ID. You all, I'm sure know what your respective corp IDs are. We use the DCN, the document control number of what CFR was used to propagate the information from which we base these payments. And now we'll talk into, the format, just get you, so we have the kind of causes or the factors along the trunk of the tree here, labeled A, B, C, D, E, F, G. And then across the, in essence, branches, we have the authorities, HCBS Medicaid, non-HCBS Medicaid, state plan, and then we also have the non-Medicaid component here that would have been factoring from any, reported direct care spending on, assistive support payments, mirrored Medicaid services, transportation, things that are not a clearly definable category within the other two buckets, right? Family support service contracts, et cetera. So now that you're oriented to the general framework, we provided the MMIS ID that the payments were loaded to, or in the case of about 10 or so agencies will be loaded to as we try to correct for mergers and auspice changes. So just going down row B, we've identified the Title Code 200 series total personal service expense from the CFR-4. In this illustrative example, the HCBS Medicaid, so, I don't want to delineate what services are in which bucket, but, think of, IRAs, DAHAB are in here, non-HCBS Medicaid, think of clinics, state plan, ICF day services, and again, non-Medicaid, think of things that don't fall into a clean bucket like transportation or, contract-based payments. So we, corralled information and summarized it into these, three, in essence, buckets. Row C is any adjustment that was made to the total PS dollar for any mergers or auspice changes. So in this illustrative example, this fictitious agency took over some waiver programs, and that agency's CFR had reported $550,000 of direct care Title Code 200 series PS expense. We now then add the two together, B and C, to give you your total final adjusted, Code 200 series CFR4 PS dollars that were reported in either the 18, 19, or 19 CFR periods. Here you can clearly see in row E the longevity payment percentage, 20%, right? That's been well documented. And when you multiply D and E together, so we're taking 20% of $3.55 million in this case in the HCBS Medicaid column, and we arrived at a payment of $710,000 in the HCBS column, $300,000 in the non-HCBS Medicaid column, and an interesting dollar amount of $51,111.11 in the non-Medicaid column. We then applied a mandated fringe percent, again mandated, right, trying to reflect all of the associated liabilities providers would have, in this area. Just a note, if you actually had a CFR where there were reported $0 fringe benefits, there was a 0%, but I know that there are a handful of new agencies that had not filed a CFR in the base year period, and what we tried to do is give some recognition, not to overly advantage with an average. We gave other than 0, we gave the lowest fringe benefit rate, mandated fringe benefit rate, so it was 2.07 roughly % is what was used for those that may not have had a CFR in the period. Or if you only had CFR 4A related expenses, because clearly there would be no mandated fringe associated with their contract payments for direct care staff. So then you multiply the PS value with a bonus by the mandated fringe percentage. In this case, it was 11.1%, and you can see the corresponding products. It was another $78,810 for the waiver services, $33,300 for the state plan services, and $5,673.33 for the non-Medicaid services. Row I simply totals the 20% of the reported PS plus the fringe benefit value. So in this case, you can see here for the longevity payment, the direct employee payment for the CFR4 folks would be these respective amounts. Now, where it gets a little different here, and why I made reference to the CFR4A, is we tried to follow the rate methodology that exists today in providing funding for for the CFR 4A. We did not simply pull in your CFR 4A related expenses. We looked at your hours because the expenses may include things like admin and overhead for the temp services agency or the contracting agency. So we're not going to just give a flat 20% on admin and related contract liabilities. So what we did is we tried to adopt the same philosophy and approach that the current rate methodology employs, which is to give the same wage treatment to the CFR 4A hours as reported in the CFR 4, or CFR 4A and your CFR for 18, 19, and 19. So looking at row J, these represent the CFR 4A hours that were reported with direct care, Title Code 200 effort. So 22,000 hours for the HCBS Medicaid, for the state plan 10,000, and 0 for the non-Medicaid. Again, because of mergers in this case, the legacy provider had 1,000 hours of CFR 4A hours that were reported in their CFR that we brought into the succeeding agency's payment. And that's row K. In row L, this just reflects the sum of those two hours. Again, the direct agency's CFR 4A data plus the merging legacy providers CFR 4A data. Can I just advance to the next slide, Tisha?
I can do it.
Thank you. So now this is just still a longevity payment, and now we're looking at M through W. So what happened here is when we calculated the value of the PS for Title Code 200, we also looked at the hours for the sending agency of the CFR 4. So let's just use an example here. If the PS benefit of the 20% was $3 per hour for CFR 4 employees, we took that $3 per hour, and this isn't the example here, I'm just giving you a sample calculation, and applied it to those CFR 4A hours, okay? So again, it was the direct employee benefit, that hourly benefit that then was transitioned to calculate the CFR 4A amounts that we would be providing. So you follow that same logic here, we would have a $125,000 value for the CFR 4A of the provider, and it's base year 18, 19, and 19 CFR. We brought in about $8,300 in similar treatment from the legacy provider. So again, those wage rates may be slightly different because we are using the legacy provider's dollars when we were calculating the payment and building up. And then that adds into a longevity PS total for the CFR 4A, the contracted staff of $133,333 in this example for a waiver, and about $55,000 in the state plan column. We then applied the same mandatory fringe benefit percentage that we used earlier, the 11.1%, roughly $14,000. I'm not going to read, roughly $14,800 here and $6,100 in row P. And then we added the PS benefit plus the impact of the mandated fringe benefits to get you to calculate in this example $148,132.96 for this provider in their Medicaid CBS column, and $61,105 in the non-Medicaid column. So again, I just want to pause there and kind of reiterate. For the CFR 4A, we did not look at any of your CFR 4A PS costs. We simply applied the benefit to the direct employed staff to the CFR 4A hours. All right, and that's how the current rate methodology works in terms of treating those CFR 4A hours. So we brought parity to that calculation. So now that we have calculated your independent longevity benefit, both PS and mandated fringe for CFR 4, your direct employed staff, and your CFR 4A, your contracted direct care staff, we simply add the two together, and in this case, row R would show that the combined benefit for both CFR 4 and 4A is $936,942 in the HCBS column, and in the state plan column, $394,405, and so on and so forth. All right, so before I get into the family care, the S and the T, which we'll jump into in a second, just you'll have to, because we did follow separate methodologies here. We didn't necessarily use the CFR data. We had to do something a little different based on what was written and provided in the Appendix K that authorized these payments in the first instance. So we'll chat about that in a minute, but just know that in this case, you'll see the supplemental rate schedule that this provider received $44,444 in the equivalent of a calculated difficulty of care payment increase of 20%. And then for the self-directed, self-hired staff liability, they received $22,222 as the calculated benefit there. And we'll talk about the slightly nuanced approaches with each of these in a minute. Assuming that you follow the math, we then added the total value of these payments together to get your final longevity payment, right? So you can see here the methodology is R, S, and T, bringing us to a total. And now, I know this next line has been a source of some confusion for folks. So row V, we did, because of federal regulatory requirements, we had to prorate, and not wholly pay through fee-for-service, providers that have enrollees in fee-for-service, but also have a component in managed care in the FIDA IDD world. We've talked about this at PA and I think in our previous webinar back in December, but just wanted you to be aware that what really this represents is kind of an enrollment snapshot. And I want to be clear here that for the longevity payment, it's an enrollment snapshot as of December 2021. And so what this in essence reflects is the percentage of people that you have enrolled in the FIDA, or the number of people enrolled in the FIDA divided by your total agency enrollees, right? So what it's trying to get a sense of is who was in the FIDA, and of that, what percentage did that universe comprise out of your total enrollment base? In this case, this provider had 15% of its population enrolled in the FIDA on December 2021. So what that means is we're discounting and taking 15% out of row U to pay through fee-for-service, with the balance going to be paid through the FIDA IDD plan. Now, I've also heard that folks have been reaching out to the FIDA asking when they're going to get their payments. I want to be clear that the way we had to structure the authorization is we have to know the rates of payment for all 4 initiatives, not just the longevity and retention. So we're not in a position to finalize the rates of payment that we'll be making to the FIDA until we finalize the other survey-based rates, which Joanne referred to earlier as the COVID service and the vaccination incentive, okay? So, we're working through those timelines and processes with the health department, and we'll be, updating, through the PA and through our website, when we're getting prepped and able to start to make the payments through the FIDA plan and when the other survey-based payments go out the door. So, nothing tomorrow is going to come through the FIDA plan to make you whole on this, just to be clear, right? The sense of timing that we have would be ideally, this quarter of the calendar year, but, there may be impacts to that timeline. So just hold tight. So what this really reflects is because 15% of this fictitious provider's population was enrolled in the FIDA in December of 21, their final longevity payment will be 85% of the $1,003,000 that was calculated in row U. So in this case, that same percentage, we looked at it in the aggregate, not by funding type or anything. So that's why you see the 85% in both the state plan, the middle column, and in the waiver, the far left column. We use that. And because the FIDA does not engage and pay you for non-Medicaid related activities, if this fictitious agency would have received $56,784, 44, offline, probably within the last few weeks, directly from voucher processing here at OPWDD. Okay, so that's why in all providers, even if you have an enrollment in the, in the FIDA, the non-Medicaid is always going to be 100% because the FIDA does not cover non-Medicaid payments. All right. So that's kind of a walkthrough in row V, and again, just can't stress this enough, you know, that these monies, the balance of the monies will in essence flow through the FIDA. What'll in essence happen, and I'm going to simplify this, but this fictitious provider, Corp ID 50, will have its name, you know, in a backup schedule that'll go to the FIDA plan with the dollar amount, which is in essence the difference between W and U, right? The aggregate dollar amount is what the FIDA will receive and will then, you know, pay out to this, you know, 00000 Corp ID agency. Okay, so there will be a kind of specific schedule attached that the FIDA will have to adhere to. So now we'll just talk for the next few minutes about the retention payments, and we'll jump into the supplemental rate calculations. Okay, so this is, thank you, Leticia. So this is the overview of the rate, the retention payment. It's identical, okay? So I'm not going to spend as much time going through this. It's the same calculation. You know, you can see up through L is, you know, the same dollars, the same hours, the same everything that we have provided. Next slide, please. Now, what I want to kind of draw your attention to is really, again, it's all similar up until we get to row V, okay? Because the snapshot changed, all right? In the snapshot for the retention payment, it's based on the January 2022 enrollment snapshot. Again, same concept, right? Percent in the FIDA, you know, number of people in the FIDA divided by total agency enrollments. And, you know, here in this case, this provider had a reduction in the number of people who were enrolled in the FIDA. So, you know, it went from 15% in the longevity payment to 12% in the retention payment. All right, which is why this is now an 88% of the total value is going to be paid through fee-for-service. So again, everything is identical between the longevity and the retention from A through U, and then column V will be, you know, and this is an example of where it changed. Other, you know, providers may have not had a change. They may have had more enrollments in the FIDA. It's just a point-in-time snapshot. At the end of the day, you know, the provider will be made whole, you know, in this case, by taking $1,003,608.96, multiplying it by 2, right? In this example, the provider will, however, get paid through 2 sources. Most of it is coming through fee-for-service. The balance, when we get to a position, we'll be working with the FIDA, you know, with PHP to effectuate that subsequent payment to make that provider whole. And just to reiterate here, and so you can see here the final retention in the blue. This is really the summation of W for both the longevity and the retention payments, and shows you what your remittance would have said in eMedNI for the HCBS and the non-HCBS Medicaid columns. And the 113 in this example would have been paid directly to the agency by OPWDP. As it relates to Medicaid, just to again reiterate here, the HCBS portion of the payment was paid via a single lump sum payment in Medicaid cycle 23-24, which I believe paid out on March 23rd of 2022, okay? The non-HCBS Medicaid payment was paid in Medicaid cycle 23-25, so a week later, cycles are weekly, and would have been paid on March 30th to the provider agency. And I just want to clarify, we'll give an example of a kind of a screenshot of what we see in eMedNI, and I know some of you may be using billing intermediaries, so I would ask that you work with them to get a better understanding of the level of detail, because we've seen some questions here about, well, my average Medicaid cycle is this, so you shorted me that in the value of my lump sum payment. No, you really need to work with your billing intermediary or billing department to make sure you're identifying these amounts appropriately. There is a specific lump sum reference in eMedNI that will show you how much are associated with these ARPA payments. Next slide, please. So as I promised, we're talking a little bit here about the supplemental payment calculations. Again, you see the kind of same example, right? Corp 000, so we know it's the same agency. But here we're trying to talk more about now the family care payment. The next slide will talk about the self-directed, self-hired payment. So what we tried to do here was, you know, the way the Appendix K was drafted said that the value of the bonus to the families delivering family care would be equivalent to a one-time 20% of the annual difficulty of care payment, right? So it's not really simple. It's not necessarily identified discretely in CFRs. So what we tried to do was look at billed data, okay? And there's the note down at the bottom of this slide that clearly indicates that we looked at paid claims through Medney for the period of September 1, 2020 through 8/31/2021. Now, that'll be the same period we'll talk about going into the subsequent discussion on the self-directed, self-hired, but we were looking at actual utilization to make these payments. So in this case, right, this illustrative agency, you can see here just kind of orientating you to the chart. We had ISPM scores of 1 through 6. We had, again, because of some agencies were impacted by mergers or consolidations of, family care components, we have the base amount that's attributed to the agency that's receiving the payment. We had mergers where they may have taken over responsibility for delivering services, for a legacy provider, and then we had a final that would simply add these together. Now we have the value here of the annual difficulty of care payment, and then we show you what the calculation is of 20% of that. And then we go into units of service here, right? So the same thing that we were doing with unique service recipient counts, we're doing with the billed units as reported through Medney. When we pulled this data in, I think it was like mid-October, November of 2021. So what you can see here is the units of service associated, the base, the 2,888 are associated with these 8 individuals who have an ISPM of 4. We have 3 people who had 888 units of service in that 12-month period who had an ISPM of 5, and we had a total utilization units of 3,254 for the 16 people who had an ISPM score of 6. So we then, take and weight those units here, calculating the 10,630.37. You can see that in the weighted payment column. You add all of those together, and the longevity and retention payments each come out to $44,444. You'll recall that was what we had shown in the summary rate sheet overview, right? So these totals will match row S of both the longevity and the retention rate sheet, right? Again, we added everything together in the final rate sheet to take the FIDA per split percent. It's not being done in this supplemental. It's just being, performed here to give you some backup as to how we calculated the payments for the family care. Okay. So we also had a slightly different approach for the self-directed, self-hired folks, right? So what we wanted to do here was give you some backup as to how we calculated the amount that we paid for those people who are self-directing and have, self-hired staff where the FI is the employer of record, not the agency. So what we did here is, again, we looked at self-directed SEMP, self-directed ComHab, and self-directed Prevoke, those easily identifiable, discernible units of service for people who self-direct and self-hired. And what we looked at here is in row A, is the units of service, right? We didn't have to worry about difficulty of care inferences with, ISPM scores. So what we tried to do is look at, again, billed data from the same period, 9/1/20 to 8/31/21, and we'll talk in a second about what C is. And so we pulled that in. We then divided by 4 because we're converting quarter-hour units of service to hourly units of service so that we can compare with row C, which is the average effective wage that the FI has. So what we looked at and what Joanne's team looked at, over 21,000 approved budgets, all right? This was no easy task here. And they came up with an effective wage that was approved through those self-directed budgets for that FI, okay? That's what this row C represents. The effective, I would just call it the weighted average hourly wage for all people who have approved, budgets, whether they be self-directing, self-hired SEMP, ComHab, and Prevoke. In this example, 00000 had a $15 an hour effective wage, right? So then, again, the same thing, the bonus is a 20% bonus. So you take your 667B times $15 an hour, right, at the equivalent of an hours of service, times $15 an hour, times 0.2, 20%, and we got to a total bonus payment here of $20,001.80. All right? And in this case, there were no mergers, but we did try to reflect mergers, and I just want to kind of let folks know that where we saw that there were like discrepancies between billed data and, you know, providers, we tried to move enrollments in the base file from where they may have billed to where the successor agency was, or vice versa, right? So we did make some adjustments to that. We also know there was an organization, you know, that had some enrollments that we were trying to work to kind of ferret out the enrollees to, you know, the new FIs. We try to take that into consideration. If you just decided to change your enrollment on January 2nd from one FI to another, we did not pick that up, right? As you know, this has been a very lengthy process to calculate these rates, to double check and triple check to make sure they're accurate. So we had to make some judgment as to the timelines involved and everything. The same thing with the CFR data. I've gotten questions about, well, I submitted a corrected CFR. Well, that's great. We used the CFR that was certified and on file, right? So the payment is based on that. We have a consistent methodology. That's what we tried to do here to be as fair as possible. We did explore some other options here with the self-directed, self-hired, looking at all approved budgets, not looking at utilization, looking at the CFR data. This approach was kind of like the middle of the road, right? And I think that this was reasonable and fair given how we had done, you know, the family care, looking at billed units. So what, in this case, again, you then bring in the agency's mandated fringe percentage. Remember, if we're paying families a difficulty of care payment in the previous slide, there's no mandated fringe liability. It's in essence the equivalent of a rate bump for those families. Here, again, because the FI is the employer of record, they're employing the self-hired, you know, staff. They bring in their 11.1 mandated fringe benefit percentage times the 20,001.8, and you calculate your longevity and retention payments of $22,222. Again, they match row T of the previous longevity and retention rate sheets that we went over. Okay? Okay, next slide. So here's what the long-awaited unveiling, because we wanted to kind of show you what we see when we look at remittances, you know, in eMedNY. And so just to be clear, like what I've heard providers say is they've looked at the net payment amount at the bottom of the screen. What you really need to talk to your billing agents and look at is this lump sum payment amount that's highlighted in purple, okay, this 1736243.51. That is the amount that if you go back to the second sheet of the retention worksheet, right, rate sheet, we'll see that's the combination of longevity and retention payments inclusive of CFR 4, 4A, family care, and self-directed, self-hired payments adjusted for the respective FIDA IDD enrollment percentage splits, right? So again, I'm not going to go back to the screen, but if you're able to flip back, you can see that that's the value under the HCBS column. So this is just an example of the HCBS waiver payment that you would have received, all right? So you'll see here in this example, and I'm not a remittance expert, but the claim payment amount is really what's associated with your traditional claiming that's due to you in cycle 23-24. In this case, this provider had no retro rate payments, and they received a lump sum payment of $1,736,243.51. So in this cycle, your billing agent would have seen that you got paid $1,760,898.66. But you should make sure that you're working with them to understand how this breaks out between the traditional claims amount and the lump sum. Again, you know, we've seen examples about, well, my average is $660,000, and so you shorted me by like $3,000 in my ARPA thing because the rate sheet doesn't match. Well, you need to go back to the remittance and look at what really happened, because your average of $660 was less, right? So what would have been posted to eMedNY and shown up in your remittance are going to be what's in the rate sheet calculation. So again, I think the note is just trying to show you that in this example, the lump sum is an additive amount to your kind of typical claiming amount that you would see, all right? I think I think that concludes my component of the presentation. Yeah. Yeah, so, just again to reiterate, I know Joanne, has shared, in the introductory section, some of our reference sources. But again, here we have, again, just referring you here, these are direct links to the OPWG FMAP webpage, which talks generally about all of our, FMAP investments. We have a workforce stabilization initiatives frequently asked questions, which you can see is the link here, right, which Joanne talked about earlier. These FAQs will be updated regularly, so I would encourage you to kind of look at them. We're not going to be sending out emails saying, oh, what's new today on the FAQ website, but just make sure that you're looking back here regularly, because I think a lot of the questions that we've been seeing have already been addressed, through the general direction and guidance that we've given on our FAQ website. So I would just, work with, either if you have questions internally, I would suggest that you reach out to your provider association reps. I know that, many PAs have worked together to be a resource to their member agencies, work with, attorney, labor attorney, to the extent you have that, corporate counsel, look to use other resources to ensure that you're adhering to the tenets of the benefit here that we're trying to provide to our direct care staff. We also have the Appendix K resource for those of you who are interested in reading, what the approved Appendix K says vis-a-vis, these initiatives, so that's out there as well. And as Joanne said, I think we'll be, sending out a mailbox that'll hopefully be a way to consolidate, any questions, though I would hope, that you work through those issues internally, because again, we're not addressing provider implementation, specific implementation issues. We're not going to be addressing employee issues. If an employee, which we've had many already call, asking why they're not eligible, we're referring them back to your HR department. It's not on OPWG to determine eligibility for this initiative. We don't have access to the payroll data necessary to make that determination, and we don't want to speculate and cause any issues here. So again, it's in all of your collective best interest to make sure that you read these materials, understand them, and then work to implement and document your decisions, as you go forward to implement. Okay? All right, I need to take a drink now.
All right, everyone, that is the end of the presentation.